Hello and welcome to the Complete Physio podcast. Now, we've got a very popular podcast on Achilles ruptures and whether these should be managed with a surgical option or whether they should be managed conservatively or with non-surgical options. Today, I'm joined by Jarrod Antflick. Jarrod has probably seen more Achilles ruptures than anybody. He's a physiotherapist, extremely experienced, and is also doing his PhD currently in Achilles. So thank you very much for joining us, Jarrod.
Thanks for having me.
Now, we were having a chat before the podcast and we asked each other, if we ruptured our Achilles today, which I hope we don't, how would we decide to manage them? Now, I went for a conservative treatment and we can talk later about why. And you went for a surgical treatment. Now, we've had so many emails from the first podcast asking, I don't know what to do. And a lot of the time they've been treated conservatively, for example, on the NHS, but they're considering surgery. So let's get straight into it. Why would you go for a surgical option?
So yes, I would go for a surgical option. I think longer term, you have a better outcome. And I think a lot of it comes down to your age, your body mass, your athletic endeavors. And not to say that I'm hugely athletic and things like that, but I like to snowboard, I like to run and play different sports. And I think that's what it really comes down to. If, I'm healthy enough and if the patient is healthy enough, then I would, and they'd like to play a lot of sport, I would 100% encourage a surgical repair. Now, there are many kinds of surgical repairs, but one of the reasons I think I would encourage a surgical repair is some of the research that's very, very new that's coming out of Denmark, and some of it hasn't been published yet. There was a paper a couple of weeks ago that's a prelude to some of the work that they're doing, is we understand that even with a surgical repair, you put somebody in a boot and within the first 2 weeks, they have a 20 mil lengthening in the tendon / muscular tendinous junction.
So for a layman, do you want to just talk through what you mean by that?
So even though you're probably not putting your foot on the ground, even though your foot is in a boot, you're going to get lengthening of that tendon or that calf by 2 centimeters or 20 millimeters. And
what's the problem with that?
So the problem with that is that you end up having a bit of extra compliance, which makes it very hard to generate force. So, it's like trying to pull a tablecloth off a table that's got things on it, trying to use a rubber band. You can't generate enough force to actually pull the cloth off, or if you grab the tablecloth and yank on it, you may get the tablecloth.
It's a very good analogy.
That works. I think I just made that up.
Yeah, it works.
But I think in the end, the surgical repair, we know that you have, a consistent fixation. The surgeon has ensured that the ends that need to be together are together. It's usually, I encourage the surgeons to do it as tight as possible because of this 20 mil lengthening. And most of the surgeons I deal with at Fortius know that to do it as tight as possible. And then you have this bony anchor into the calcaneus. So I think that's really important. We want to limit the lengthening. We want to ensure that the two ends are together. Now, I do see a lot of Achilles and I do rehab both. I think I take the ones that are not surgical, I take them a lot slower. Some of them have fantastic outcomes. Some of them don't. And it's the ones that I don't that they've gone 4, 5, 6 months of doing some rehab.
And you remember those ones, don't you?
Yeah, and they end up having to go and then have surgery and go through the whole process again. Whereas when you have a surgical repair, you know that the ends are put together, and as long as you don't do all the silly things like fall down the stairs, stick on a slippery surface or stretch it, that you're probably going to get a good outcome in the end.
And what about the sort of negatives of surgery? So you do have an increase, you've got the risk of infection.
DVT.
And DVT. So it's DVT. So these are quite low risk, but obviously in your reasoning, you've thought about that. So talk us through how that fits into your decision making.
So I think there's a risk with any surgery. But I think with the surgical for Achilles, we're now doing something called a percutaneous repair. And I'm obviously not a surgeon, but the surgeons will always try, at least at Fortius, a percutaneous repair, which is a minimally invasive. The incision's horizontal. It's probably maybe 2 centimeters long. And they draw down the tendon with a PARS device, and then it inserts in, with the rest of the stump into the heel bone. And those ones are, when they're done really well and, things are fixated very well, their outcomes to them are really, really good, and they rehab very quickly. And they come out.
And because the scar's smaller, your risk of infection
is very low, and adherence as well. So recently I've actually seen two where we get this sort of, it's a strange term called puckering or adhesion of the skin to the paratenon. And they can be, in the last two that I've seen, have been quite painful. And now these aren't 40 years patients. These are patients that have come in from, different places, and they get this adherence. And it can be painful if you imagine someone pulling on parts of your Achilles tendon and on every step. That can be really, really uncomfortable. And so those then go for a surgical debridement. And they're the risks with surgery, is that you get these risk of infection, obviously risk of failure, but also some of the puckering and some of the other maybe potential keloid scarring in our Afro-Caribbean populations that rupture their Achilles. So,
and also you were mentioning earlier when we were chatting before the podcast that from a physio point of view, you like the reassurance that you've got those two ends together and you do get more strength in that repair because of the way they repair it relative to conservative. So talk me through that.
I'll go back to a conversation you and I had, which was, I'm always worried that they're going to come apart. So I ultrasound them to make sure.
Yeah.
So with the surgical repair, assuming the surgery is done very well, and let's assume that it is, I'm not so worried about the fact that at 8 weeks when I get them walking that they're going to lengthen or that they're going to come apart. And I don't need to ultrasound them. I actually do ultrasound them at 12 weeks to make sure that they've got a good 1 square centimeter of thickness to the tendon, because the outcomes are much better at 1 year. But I don't worry about those sorts of things when they've had a surgical repair. That being said, some people are not appropriate for a surgical repair. And I think, I've got a couple of people that are actually really quite athletic that have had a conservative repair and actually done really, really well. So I think, with outcomes with all surgeries, things like your body mass, your fitness, whether you drink, smoke, your diet, all those things are really important. And it doesn't matter if it's an Achilles repair or an ACL. Those things do have a role in your outcomes longer term, whether you get better or not.
Do you think from your experience that people that have a surgical repair get back to sport quicker?
I think they do, because I can get them doing the things that resemble them returning to sport a little bit quicker. The downside is, and we were talking about this a couple of days ago, was depending on the type of suture technique, and there's a couple of different suture techniques that surgeons use. There's a crack arm, there's a Kessler, and then now there's a speed bridge, which was made famous recently by an NFL player.
Who got back after?
Well, I mean, he's walking without a boot at 2 weeks.
And I think
Aaron Rodgers.
From the people that have watched the podcast, and I'm getting the emails,
horrified.
But they're
excited
they
about
quote
it.
These things. They're like, I'd like to go for surgery. Look at this guy.
Yeah.
And it is comparing apples with pears, really. Isn't
it? So I think the Aaron Rodgers case, I have to do a presentation on Achilles repairs, and that is the perfect case of an athlete that has made all of his decisions for him medically himself. And I won't quote what one of the agents has said, but that is not realistic.
No.
2.5 weeks of walking around without a boot on, you will, no matter who you are, and particularly for someone of his age, at 41 years old, going for a surgical repair. And, they talk about the speed bridge, which is the new technique. It's not really. The speed bridge is just a different technique with a little bit more suture material around the tendon. Interestingly enough, that's often done, not always, but often done with a particularly bad tear.
Right. Okay. So
it will be like, it might be a Kessler with a cracker whip stitch and then a speed bridge along the side. Surgeon dependent. But one of the things that I often see with these surgical repairs is that we distal to that repair site, even though there's nylon going through the tendon, I often see, because there's so much nylon around that repair, distal to it, we start to see these changes in the tendinopathic changes, because you've got this very stiff repair with all the nylon around it, and then the tendon below it's got to adjust to it.
And you get that through the rehab process, you develop that.
Yeah, so, over the last couple of years, I've seen, as we start using, more nylon or more interesting nylon and stronger nylon around the repairs, that the tendon around it, because we've been these patients have been in a boot for 6 to 8 weeks, the tendon stiffness or the properties of the tendon drop. Then we get them walking and they start to become a bit more symptomatic, distal to the repair.
Yeah.
And that's, I've seen that in, basketball players in the US where they've had the repair, and unfortunately distal to it, they become very tendinopathic.
Yeah.
And that's probably because, and the repair site looks good, is the repair is so strong and so stiff that the area distal to it is becoming problematic. So those ones, there's probably a downside to it because we try and get them back quickly.
Yeah. And when we obviously, when we look at the research, and a lot of people watching this, they're not going to be reading the research, but actually people do, they look on Google Scholar. But talk to me a little bit more about the function of the muscle following rupture. So what I mean by that is when you rehabilitate these, you've got to get basically people be able to do a single leg calf raise. And what's your experience with getting that single leg calf raise and trying to get that muscle bulk and that heel height back after conservative versus surgical repair?
So, I mean, I think the conservatives, because I make them more conservative, I delay.
As in the rehab is slower.
Yeah, the rehab's a little bit slower. I think they have a delay in the ability to get that muscle mass. I like to add some adjuncts, which, interestingly, I saw an ESPN article on this Aaron Rodgers case where, they were using this, very cutting edge technology, which was blood flow resistance.
Right.
And blood flow resistance is not
We've been using that for 10 years here.
Exactly. Well, you and I both have. So it's not that cutting edge. It's just more accessible and easier, and there's more cuffs on the market. But, I like both, whether it be surgical or conservative, I like them both to start early if the surgeon's happy with it and there's no comorbidities. And I think that's a really nice way to get the calf mass up, because the biggest issue that we see, and this is why the Danes are doing what we call a double bundle repair or a deep and superficial repair, is that the tendon actually has this helical angle. It spins, and it's sometimes up to 15 degrees. And that helical angle is really, really important to generate the stiffness, which is the ability to go and calf raise or hop and skip. You lose that once you rupture.
Yeah.
And so that's one of the reasons why people sometimes don't fully get back their strength, because the anatomy has not been fixed to the way it once was. And creating a helical angle is nigh impossible because the fibers, you can't get them to turn that way anymore. So trying to get that muscle mass is always a struggle, but I like them to
with
start
both surgical
with both surgical or conservative. Makes little difference, but at least with the surgical, I think that I can get them starting some stuff a little bit early. Maybe it's just me. I'm worried about them, opening up their rupture site when it's conservative.
And for some people, being, one of the reasons I would say conservative for me is that I'm not against the clock.
No,
I don't care if I get back running at 4 months, 5 months, 6 months. So I just want to get back, and I'm not bothered about the rush. So that's one of the reasons. And the other reason for me is, and I get this question a lot, is that can you get back to sport with conservative treatment? The answer is yes, you can. However, I'm 44. I know I don't look it. I'm 44. If I was
45 very shortly, I believe.
I'm 45 next week. But if I was 24, I was doing so much more.
Would you get a surgical?
I can't speak on behalf of the 24-year-old of me in 2023, but I think I would have been more likely to have a surgical repair because my sporting endeavours now are different. Now, I'm 44. I'm not looking to run a marathon. I'm not a master's level sprinter. But if I was, and the sport that I loved doing was to, say I played basketball at 44, I think I'd go surgical for the reasons that you've already alluded to. So, and I think it's a very individual decision.
And that's why I said at the very beginning, it's very sport dependent and person dependent. And I help people. I don't make the decision for people. I help people come to a decision. So, I often get emails.
Which is why we're doing this.
Yeah, exactly. So I often get emails from people, what would you do? And I was like, what I do is going to be entirely different to what you do. So if you're a 24-year-old that plays football 3-4 times a week and you like to run and you want to do anything other than just play golf, then I would suggest you get a surgical repair. But if you're how old are you again? 44, sub-elite athlete that wants to get back to doing just day-to-day things that keep you fit, then absolutely,
like a gym class.
Exactly.
You can
I think a conservative, and if you're not in a rush, my problem is I'm probably biased we're all biased, but I think I'm probably biased because I see so many elites that are coming back from. My head is, well, to get you back quicker, I need you to have a surgical because, you know, it reassures me again, all of the comments we talked about.
What about re-rupture rates? This does come up in conversations. So where are we in terms of, am I less likely to re-rupture if I have surgery versus conservative?
I think if you look at the NICE guidelines or some of the NHS publications, they say no, you're not. But unfortunately, the people that are presenting to the NHS are people that probably don't have huge athletic endeavours. John and I have seen quite a few. I've seen quite a few that will re-rupture because you're hoping, fingers crossed, that by putting them in this end range plantar flexion that you're going to get close opposition of these tendon ends and they're going to scar. The problem is how good is that scar? And we're relying on, unfortunately, the body to heal something that is imperative. The argument comes down to some of the ACL research. You know, do we think, and there's a paper that came out a little while ago looking at 3 months, a lot of these ACLs, if you let them scar down, will scar together. And if you ask Tim Hewitt, he will say they may well look scarred, but are they functional enough to stop that tibial translation and rotation? The answer is no. And so I don't know of any elite athlete. I mean, there's probably some out there, but high-functioning Premier League Championship, NBA, whatever it be, that's had a conservative repair or conservative management and return to that level. Because I often see the problem is the lengthening. If you get this lengthening, it's very hard to generate force. And interestingly, athletes will describe it as sort of, you know, it feels like a flat tire. It feels like I can't push off. I don't have the same pop as I used to. And that's because the tendon's lengthened.
And in elite sport, you can't risk it, can you? That's the thing.
Not in this day and age. I think both, you know, I work across different sports, but Premier League football is the fastest, you know, football organization or championship or league in the world. The NBA is the same thing. And so, you know, you can't afford to be just a little bit slow because you just get caught out.
No, exactly. And you've talked about it a bit there, and I do want to go on to that, is that because of the NICE guidelines, so in the UK, the NHS will probably, I don't know, if you walked into most A&Es, you won't even be given a surgical option.
No,
so
you won't.
You are walking out of A&E being treated conservatively, hopefully in that plantar flexed position. And I've certainly had people that have emailed in following the first podcast and said, I was treated conservative. I watched your podcast. I went back to A&E and I said, I want surgery. And they've got surgery. So a bit like, if you don't ask, you don't get. I think most people are going down the conservative route and get very worried that they're not going to return to their sporting endeavour.
Yeah, but again, I think it depends on your sporting endeavours. So, and your age. Like we talked about, what would we do? I think it's a difficult one. The NHS is struggling as it is with things other than, and I don't want to say more important, but arguably more important conditions that are arising at the moment in the modern world. Achilles ruptures is not one of them. And
they don't really care whether you can get back to your
sport or not.
You know, when you've got somebody in the next cubicle that's having a heart
attack or dying or has long COVID or whatever. Exactly. So I think the NHS potentially is not really coping with its demand. And therefore that's probably an easier option to put them, that patient that's ruptured in a boot and off they go.
Isn't it? And it's an option that has been shown in most people to be effective.
Exactly. And so that probably answers that argument. You know, if we were living in a different country, in Australia or the United States, they don't do a lot of conservative, but that's driven from a different reason.
For private healthcare.
Exactly. So I think there's a happy medium in there, and I would generally say the happy medium would be something along the lines of, it depends on the patient. You know, if you are, like we talked about, an older person that really only plays golf, that isn't in a rush to get back, 100% I would go conservative.
And the other thing, just to add, although I would go conservative, I know what optimal conservative management is. And if I, along the way, felt that I wasn't optimally managed,
you'd go and have a surgical.
I would have surgical. So the examples that we get from emails and from seeing patients is, I went to A&E, they said I hadn't ruptured it, and 2 weeks later I went back and they've now told me I've ruptured it. So they've been walking around, even for 2 or 3 days, not necessarily 2 weeks, they've been walking around without a boot, and that is unfortunately likely to not just lengthen, but it means that the two ends are no longer together. And quite frankly, if they're not together, it's not healing.
Exactly.
And then you can end up, and this is where, although it's not life-saving, there's a quality of life element.
Absolutely.
Because if that Achilles doesn't come together and you can't push onto your toes, I mean, your lip.
You can't drive.
You can't.
If it's the right foot.
Yeah.
You know, you can't go up on upstairs. You know, and if you've got a young family, if you're of that age, or if you've got grandkids, you know, you're really going to struggle. And so there is a massive quality of life that's affected by an Achilles rupture.
Yeah.
So yeah, I think I would always say it depends on the patient. And the surgeons I work with, I think, are very good at that. They don't always, recommend surgery. I think it really does depend on the patient.
Yeah. I'm going to ask you one more question. It's not a straightforward one, but I get this a lot. I've had an ultrasound scan. They've told me I've got a gap of 0.8 millimeters, so it's less than 1, which does seem to be the cutoff in a lot of clinics. Or I'll get somebody that says, it's 1.2. So there seems to be this cutoff at 1 centimeter that you should go surgically if it's larger than that or less. Now, from somebody that scans a lot, I don't understand that at all.
No.
Okay, good.
Yeah, because you can quite simply just put somebody in plantar flexion and then it'll just go to 0.5.
Yeah, and also it's not a reflection of the lengthening, because as you just said, these aren't twigs that are snapping. These are things that spiralize up, and essentially it's a longitudinal tear, isn't it? So the cross section it just doesn't fit like that.
No, exactly.
But I suppose my ongoing question from there is there a case when you have to have surgery? I assume it's just when you can't get those retracted ends together.
Yeah, I think when you can't get those retracted ends together, or if they are together and not enough of it's together.
Yeah.
Or
that's quite subjective as well, isn't it?
It can be. I think, listen, if you're at 4 months, okay, and you have obviously no muscle tone, you can't plantar flex particularly well.
You don't have much of a squeeze.
Well, the squeeze test it's not a particularly good indication, and I'll tell you why. Mainly because these people have had 4 months of not really using their calf. They've lost muscle mass and tone. One of the things that I look at is these 3 positions. So I get them prone 4-point kneeling.
So
and
on your hands and knees.
On your hands and knees, and I see the angle of the dangle, essentially. The second one is lying face down, so we get a bit of gastrocs involvement and see what it looks like then. And then the other one is prone with a knee bend, and then I put them in plantar flexion and let it drop.
And basically you're looking for the toes to be higher or further back than the heel.
Exactly, and if you're at 4 months and you go completely this way, you're probably, it's not going to get any better.
No.
The more conservative I treat you. So I think those people, they end up having to have a more complicated procedure, which is a shortening procedure with an Achilles repair. Now, it's not that much more complicated, but essentially it is, because you're repairing the rupture, but you're also having to shorten it a little bit. And so that can get a little bit more challenging, and the wound is actually usually a lot bigger.
It's quite big, isn't it? And that's a question I've had is, I've been treated conservatively, or I've re-ruptured or something like that. What about optimal timing of surgery? And could you have let's say, for example, I treated my Achilles conservatively, but 4 months down the line, I wasn't happy with my function. Could I then have surgery again?
Of course you can.
Yeah.
I mean, these are more questions for the surgeons that do it. But, I think in the first instance, if you've ruptured your Achilles, getting it repaired as soon as you can, because all of the exudate and all the material that's around that area is a healing response. So you want to put the ends together as quickly as you can so that things can heal. If at 4 months you haven't healed properly, then you're going under the knife again to get it all repaired. And it's usually a more complicated repair because the surgeon needs to visualize things.
It's definitely a bigger... I mean, it can be that, can't it?
Yeah, absolutely.
Okay. Well, hopefully that's been helpful for people that are sitting at home with their plaster cast on.
Yeah.
And we've got a few other podcasts on this, so hopefully this is giving people a lot of information to help them make that decision. So thank you for joining us, Jarrod.
Thanks for having me.